Let's call the meeting to order. Do we have any courtesy of the floor? No. We have Jessica here with a report on the Early Intervention Division, we've waited for you for 4 months. My apologies for my delaying you.
First time I was sick. I couldn't talk.
No, I think the first time my dad was sick, so we're all good. We're here.
Well, there was one point I went into I couldn't talk. My voice was gone, and she was freaking out because she didn't want me to. I got that job for it.
Oh, and I should introduce that the new members of the committee are Mr. Giovanni and Mr. Myers. They've taken the other folks' place, so they're the new members. It's myself and Mr. Hackman still.
This with my papers.
And just the way that I generally run this meeting is I try to let them do the presentation. I ask committee members if they have questions first, then I open it up to the rest of council. So.
Okay. So Tiff and Sue actually asked me to talk a little bit about the plans of safe care, which I am involved in. And even though I'm the director, Jessica Weitknecht, Weitknecht. I'm the director for the Early Intervention Program through the Department of Human Services. But they had asked me to come to talk to you today a little bit about the plans of safe care, which I'm involved in. It's a new requirement that has come out of the Governor Wolf's initiatives, and what it comes through is the Child Protective Services Law, and underneath that is the CARE Act, which is the Comprehensive Addiction Recovery Act, and then the plans of safe care is housed within that act. And in 2017, Governor Wolf signed an enactment to update that part of the CARE Act. So the Plan of Safe Care has always been under the CARE Act, but he updated it in 2017. And I sort of spearheaded it because I was involved with a fellowship that I did through the state last year. So that's why I'm actually here, because I have the most information on it. And what it is it's basically a plan of safe care for any child that's been born addicted and is experiencing withdrawal symptoms from any sort of substance that the mother was taking. And what's changed is that the word illegal has come out of that definition. So it's any mom who is taking any prescribed medication or illegal prescription, and now the baby's withdrawing from that use, legal or illegal. So a mom could have pain management, is taking an opioid, it's all under control, but the baby's having withdrawal symptoms. A referral needs to be made through Childline to our department, and we would have to do a plan of safe care for that family. The other change is that it's not just for the mother and baby, it's for the entire family. So we got together as a group in March of 2018, my years are all messed up, 2019, and went down to the Kalahari where the state put on a training for us so that we understood what our role is. And it's not just children and youth, it's the whole Department of Human Services that they want involved in this plan of safe care. So our team consists of children and youth, drug and alcohol, mental health, early intervention. We have community members from Easton Hospital, Lehigh Valley Hospital. We have St. Luke's Visiting Nurse. We have Bethlehem Health Bureau on there, and we have a drug and alcohol member now. We did have a mom on there, but some things have happened that she's not able to do it anymore. So all the referrals have to come through Childline. Although Childline is not equipped yet to take them, they still are making those phone calls into our program. So once that comes in, then we get together as a team and go out and meet with the family, and we offer them a plan of safe care. And the whole idea is that the community comes together to provide these families with supports rather than putting them in children and youth and having that overhead of, that the child's going to be taken away. It's almost like a preventative. What we've been trying to do too is doing before the baby, so prenatally, if a mom is involved in any sort of connections program or is involved in any kind of drug and alcohol and they are pregnant, we're trying to hit them earlier. We've run into a couple snags, but it's coming along nicely. We've done a handful of them, so we're not quite up to par with I can't say we're not up to par. We've just done a couple of them. We've probably done about 10 plans of safe care. And it's going okay, I would say. We are farther along than most counties. We just had another training actually a couple weeks ago, and we are, like I said, farther along than some of the other counties. What's really nice. We actually have done plans. We've done plans with families. We have a policy that is not quite written yet, but is being worked on. I have been doing community outreach with doctor's offices, pediatricians, OBs. We've actually had training in-house, and I was very happy because Bethlehem Police Department actually came as well. So the referrals really should come from anybody from the community. The other thing is, it's not just when the baby's born, it could be up to a year old. So if the baby starts having withdrawal symptoms after they're born or 6 months into it, we can get called for a plan of safe care. It's also voluntary, so a family could say no. Those, the flyers that I gave you, we actually borrowed from a county up north that put a lot of that together, and then we went in and edited it and put our information on it. But it's a very nice brochure for a family to understand what a plan of safe care is and what we can do for them as a county rather than a Department of Human Services division.
So can you give us a quick anecdote or example of what a plan might look like or sound like?
So I could just give you an example. So last family we saw, mom was a single mom, had very limited resources. So the first thing that we did as a team is we went in there and we talked to mom about what resources she needed. Did she have everything she needed for the baby? That was the first and foremost. And if she didn't, what did she need and how can we hook her up with that? And then we looked at, did she have mental health or drug and alcohol history? Was she in treatment? Did she need treatment? Did she need referrals to wherever she needed to be? Once we had that all set up, there's an actual plan. It's usually handwritten at first, and then we give them a one-page paper that says, here's your plan. This is what we need to do. This is what you're going to do, and this is when we're going to meet again. We do a follow-up meeting, usually within a couple weeks, to see where the family's at and what they've done and what they still need support with. And then we can monitor it however we want. 3 months, weekly, monthly, however we feel the family needs or what the family's in need of. Most of the referrals are children and youth already involved, just because that's just the monster of the beast. They're going to come in through children and youth because there's a drug and alcohol issue that comes in. And we've had a few families that were discharged and we sort of just did the plan of safe care and they were no longer involved with children and youth. We can house them up to a year too.
When they're born, are they automatically considered like for children and youth referral or not necessarily so? Like, because I've heard varying stories about that. So
what do you mean?
like a baby, when a baby's born and they identify addiction, does it become automatically a children and youth case?
Yeah, most of them do. Yeah. They have to have, usually the meconium is tested in the baby afterwards, because if they can test anything in the meconium during the pregnancy and it will show up. So heroin won't show up within 24 hours, but if mom did it 6 months ago, it still might show up in the meconium.
Child is born, and once the child is born, does he fall under children youth as far as medical, or does the parent have to say, since this is voluntary?
Children is a mandated service. So
that's what I want to hear.
Yeah, it's a mandated service. So if there is safety concerns, or if if mom is saying, yep, I'm addicted to heroin, I have no treatment, they're mandated reporters. They have to call it into children. They have to call Childline and make that report.
How many staff members do we have on that? And
That's not my department. That would be a question for Sue Wondolowski.
But he asked too, basically who pays for it? Does their insurance pay for it? And if they don't have insurance?
For the plan of safe care?
Yeah.
No,
If they don't
it's
have insurance, who pays for it?
it's Department of Human Services.
So basically,
it comes out of us.
yeah.
Correct. The state basically said, here it is. You have to form a team and sort of do what you need to do within your agency in order to do that. One of the biggest benefits that I feel that we have in Northampton County is that we're all housed in the same building for Department of Human Services. That was the best thing that they could have done for us, because if I need to go down and talk to somebody of drug alcohol, I can just walk down the hallway. If I need to go down and talk to children and youth, we're all right there. All our meetings are there. The families have one stop, which has helped this tremendously. Plus, we've all of our divisions, all of the heads that are doing this have all worked together for many years. So it's really working well for our county.
Did you say how many cases you have in this program right now?
A handful, maybe 10, maybe, I would say between 7 and 10. It's hard to keep track because once that family becomes involved with us, the lead agencies, the higher administration takes a step back, and usually one of the workers are assigned as the lead.
So you're an automatic caseworker?
Depends on what they are, which division needs them the most. Usually if it's a baby, early intervention is already involved, because any child that's born addicted has a high probability of having a developmental delay, so we get referrals all the time. If mom has drug and alcohol issues, there's usually a case in drug and alcohol. Mental health is sort of the same thing.
So is there any way to come back and do reporting to the central group or the central team for follow-up, like 3-6 months to? Because I realize that managers are separately managing that, but to be able to do data to report back to the state, is there a central way to do some reporting on that? Or
Internally, or do you want me to come back, I guess is my question.
No. I'm asking, like,
Status.
is there a mechanism that you all keep track? Because you've gotten the referrals, you've done the disbursement, and the state set this groundwork. So then how do you keep track of the outcomes, I guess? Because down the road, you're going to need to report.
Well,
on
this
that.
is brand new too. So this
Right.
started October of 2017, October 2018. We had the training in March of 2019 because obviously the state is always slower than everything else, and we got the training after. And then until we actually implemented it, it was probably July when we actually started doing the plans. So 2019. So we've really only been doing this for about 6 months. But what we've decided as a core team, because that's why we have those teams that we developed, and we talk about it every month about what we're doing, how we're doing it, how we capturing the data, because the state's going to come in for every division and want to know how we're capturing this data and what's going on. So what we have developed is a spreadsheet, basically. There's 4 main people that are on the core team that when a referral comes in, those 4 people are on the email so that we can keep track of it. But we have a spreadsheet now in a secured file on our Department of Human Services drive that only 4 of us have access to, that all of the information is going into that so that we have data, not just for the state, but for whoever would like to come in and see how we're implementing it and what we're doing and what's happening with the families.
And do you feel like you're capturing all the real referrals, or do you think, like, how are the hospitals and other places responding?
Yeah, most of our referrals are coming from Lehigh Valley, from Eulenberg, from the NICU there. Janice just happens to be on our team, so whenever she feels it's a family that needs it, she's been calling them in. So far, I think they've been pretty appropriate, the referrals. We did just get one where it was marijuana, but there was no withdrawal symptoms, so we kind of said that doesn't really make sense for us to do it. But obviously, if a family really is in need, we'll go out and make sure that that family's supported as a Department of Human Services. We're never going to let a family not have services, because that's what we do, you know.
So you're recording anything that happens before the baby is born. So if we know the mother has a problem, is that already in your queue and you know it's there?
It's not always in our queue. We're only getting what's reported to us. We did ask to be proactive, and I did a really nice PowerPoint, which I don't have, that I've given to all of the doctors, hospitals, anybody that would take it. We dispersed it, and it specifically says in there, here's a referral if you have a child that's unborn. Here's one that if you have a child and you have other children, this is how you go. And if you're just pregnant for the first time, this is how you go. Because if you have if you're pregnant for the first time, Childline won't accept that referral, because Children Youth won't take a baby that's not born. So I specifically put that in the PowerPoint, so these providers are very aware of how to refer and what they need to do.
Question. Mother's 3rd child. What are we doing with the other 2? Are we monitoring them? Are we trying to keep anything? How are we handling that?
The monitoring part, the plans of safe care works with the family. So we're going to make sure that the family is getting everything they need. And like I said, most of the referrals are coming in as a children and youth case. So there is a separate caseworker that's assigned to assess the safety of that family. They still have that role. This is separate from what they have to do as a children and youth worker. They still have to assess it. They still have to manage it. They still have to make sure that family is safe. Our role is to provide the services that they need so that children and youth can close. And we can monitor it for a whole year so that those children are safe, that baby's safe, that children's safe, that mom and family, grandparents, whoever is in there is able to get the services they need so that they can maintain that sobriety and their mental health.
What happens if they say no?
Then they say no, and usually what happens is if it's a family that, if it's a mom that's just taking the prescribed medication, we just close. We close. There's nothing we can do. We have a letter that says this was offered to you. We actually just developed it, but we decided that we need to do a letter that says this was offered to you, a plan was made. If you need us, call us, but you're declining what we're giving you. If it's a serious case where it's a children and youth case, they're keeping it open.
Yeah. Did you have questions?
Yeah, I just, first of all, thank you for mentioning the Consolidated Human Services Building. That was a vision of John Stofa, and, you know, I was happy to vote for it, and I'm glad to hear that it's working out well. I want to take you back to that case that you mentioned with the single mother. My question is, was the father involved as far as at least paying child support, or do you go after or help the mother get the child support that she would need?
Just depends on what the mom would like. I mean, again, it's voluntary, and we're only offering the services that what she needs. So if she would say, I need child support, I need some, or I'm financially not stable, we can recommend, well, where's dad? Is he paying child support? Why don't you file for, you know, custody, or go down to custody court and file.
But you would show them the mechanism by which that
Of course.
happens, not necessarily stand up and try to advocate that they get child
Correct,
support,
correct,
because that would be crossing
correct.
someone's boundary.
We're just providing them with the supports and services to do that.
So I just want to clarify some questions that I had, or some statements said.
Sure.
You did say that this is a mandated service, but at the same time you said that it's voluntary, a person could say no, and that there might be some, like, what would be the reasons why someone could say no, or what would be the circumstances under which it's voluntary? Like, what would deter a mom from getting this help?
So I'm just going to correct myself. Children and youth is a mandated service. This is held under the Child Protective Services law, so it's a requirement for Department of Human Services for every county to have a plan of safe care team.
So the plan is required. Now, is it voluntary participation?
Correct. Yep. A mom, we just had a mom that just said, no, I don't want to do it. I'm too overwhelmed. I'm not doing it. I don't need your help. And she said no. And we said, okay, here's all the information. Here's our cards. If you ever want to do it, please call us back.
And so the deterrent, why would a mom not want that kind of help? Like, besides pride or ego? Like, are there any ramifications that, like, if they ask for children and youth services, and children and youth services comes in, would there be any repercussions to what they have? Like, in terms of somebody's illegal drug use, because you said there's legal and illegal. So let's just say somebody is addicted to opioids and they progress to heroin. Would that person be able to get the help that they needed for themselves as a child under some sort of like, I don't know the word that I'm trying to use, but under some sort of kind of like grace period or so, because they're asking for help.
Yeah,
You know what I mean?
I think we've come a long way in that. We don't want to punish someone for being addicted
Right.
to
So you don't
anything.
incarcerate somebody
Yeah.
because they're
Yeah, we don't want to do that. And we don't want to take their kids away just because they have an issue with an illegal drug. If they're willing and able and they want to get the help that they need, we're here to support them with that.
So then do you also get the mother sort of, beyond mental health, like drug and alcohol, would you put that person in a program?
Depends on what they have. See, that's a whole factor. I'm not in the drug and alcohol program, so that's a little bit beyond my scope. However, Kathy, who's with drug and alcohol, will help mom with that process. So depending on what insurance they have, if they have insurance, that will all be necessitate of what program they would be in. I can't say whether or not she needs inpatient or if she needs, a 90-day treatment program. We don't have that ability. We just say, here's, correct. We would put them in the right direction. Refer them to. Yes, yes. Yeah.
Because you named all the services that were involved in it, and I was just wondering the mechanism by which somebody would, like, give that person a caseworker individually, and then they're able to put a treatment plan together for them so that they can say, oh, you need this service, this service, this service, this service, and then you all have that.
Correct. Yep. And sometimes it's not even a Department of Human Services worker. It could be their doctor, or it could be the New Directions facility that's working with them, and they might be the lead person that just makes sure that mom is following what they need to do and just following up with the team to make sure that everything is going smooth for that family. Again, we're supposed to follow a family for a year. We've only been doing 6 months, so I think we might have 2 or 3 families now that we've seen a few times, but it's such a new process for all of us that we're still sort of rolling through the motions and just making sure that we have all our policies, our procedures in place, and making sure that we're following what we need to follow.
Right, so by this time next year, you might have some statistics on the cost of the program.
Yeah.
Maybe some
Yes. Yep.
Very good, thank you.
While you're here, and again, because we have some new members, do you want to just briefly overview what your department does, or, the other, because this, I think, is a wonderful program, and the fact that we're ahead of everybody, I think is great. I think it speaks a lot to the hard work that Jessica and her team have done. But do you want to just outline a little bit more what your department does besides this? Because
Early
it's
intervention?
tremendous.
Early intervention, we work with, we're a entitlement program through the state, and we work with children that are birth to 3 that have any sort of developmental delay, diagnosis, or a high probability concern. So anybody can call from birth to 3, and we provide an evaluation and services if they need them. It's just a brief, slim overview of what we do.
And your staffing is?
We are fully staffed. We have 12 service coordinators, 2 supervisors, a fiscal assistant, and myself.
Sounds good. Yep. And all God's children have slots in daycares and all the placements they need, or is that different? Because I know like there was an issue last year with one of the daycares that had been long-standing was closing. You didn't know where we were going to put all these kids, so.
Yeah, we had unconditional childcare that was closing because the state regionalized our childcare information services, but they have found a home through Pine Brook, so they are doing well, and we are supporting them. I know Children and Youth also supports them as well. It's a very good program that goes into the daycares and helps children that have behavioral needs beyond what early intervention can provide those children in that child care center. Yep, so they're good to go.
Thank you. Thank you for coming. Glad we could finally connect.
Yeah.
Report from the director. And again, I'd just be mindful of the fact that when I was new and there were all these word salads and new people, if you just introduce any of your staff that's here, because maybe that's helpful as people start to hear their names for the new committee members.
It's a good reminder. I'm Sue Wondolowski, Director of Human Services here at the county. Met you, Mr. Myers. Not yet, Mr. Giovanni. It's nice to see you. So just briefly, Human Services in Northampton County, in terms of what falls under that, it's, I go in order of my building. We have Information, Referral, and Emergency Services. We have the Veteran Affairs Office, Children and Youth, Drug and Alcohol, Health Choices, Mental Health, Early Intervention, Developmental Programs, Area Agency on Aging, and Graysdale. So I appreciate Jess coming and providing that update. Jess was able to take the lead on that project, and from the feedback I got from the other folks who were on that was a very successful undertaking, and I'm sure we still have plenty of lessons to learn and things to do, but it's nice to have a system in place where we can get involved with pregnant women with addiction issues prior to them giving birth.
Right.
Obviously, the end goal is to avoid children and youth placements. So So hopefully we continue to see that go well. So sticking with the mental health developmental program folks, I think I referenced when I was here last that our developmental programs department had their, I believe, annual audit. Some folks get audited every year. Some of our departments get audited every 5 years. This is a group of, there's only 6 or 7 of those folks, and essentially we are called the administrative entity. So we oversee the service coordination providers that are community agencies for adults with developmental disabilities. And they are a phenomenal group of folks, and they got rave reviews. So I was hoping you would all allow me just a couple of minutes to read you some of the direct quotes, because it's nice to hear the positive things. So what the state told us is that our folks really know their consumers. That's what we call our clients in developmental programs. They call them consumers. And interestingly, this is unique to Northampton County. So there's a lot of folks, and they're not case managers who work directly with the individuals every week or every month. So it is a different kind of relationship than a children and youth caseworker who has much more frequent contact, which is why it speaks to it being unique to Northampton County, because our folks really go above and beyond with that. They're very responsive, which is not typical of what they see in other counties. They make strong, clinically solid decisions. The state was impressed at how our folks use the self-assessment to identify areas of improvement and already have them in place when the state comes out to audit us. So our folks are being proactive with that, identifying areas of need and growth and working on plans to rectify those. Just continuing to go above and beyond. And some of you know we had a situation with one of our providers just about a year ago, a pretty significant issue with some of the staff at this provider, and which I can't get into, but it was a pretty bad situation for our folks. And generally speaking, it's the responsibility of the community agencies that we contract with to oversee those individuals. So we had a few adult gentlemen with developmental disabilities that I asked our folks internally to monitor on a weekly basis, which far exceeds what they would have been required to do. And not only did they do that, and very willingly, I will add, they frequently did that on Friday nights and the weekends. And they're all career service folks, so they're not getting paid overtime for doing that. And they have continued to do that because that's still a situation in progress. So the state was tremendously impressed with our folks. And that's pretty much the highlight, but they just had really nothing but rave reviews. So I wanted to make sure to be able to let everyone here know that. So, and in keeping with positive feedback from state and auditors, our auditor for our Health Choices program, which is our behavioral health medical assistance program, they had their audit with our Binkley-Canavy folks, and they described the Northampton County Health Choices program as one of the elite Health Choices counties. So that's a crew of 5 or 6, a small group as well, and they all have their unique roles, and generally speaking, all go above and beyond and really work very well together to make sure that program runs smoothly. So it's always nice to get that feedback. And AAA had we all know they're green now, so we're super thrilled about that, and they are continuing to work hard. They are down a staff person, and it is...
Should say what AAA is.
Did I say AAA?
You totally did.
Oh, yeah, that's not triple. It is, but
It
an
is,
area
but-
agency on aging, not the automobile. they had their, so they are in the green, they've protective services folks who are keeping our older adults safe. They are doing very well, that's what that means. They are down a staff person, however, and working hard to get that position filled because it's been quite a struggle. In fact, just for some comparison's sake, we have, when we are back to being fully staffed, we will have 4 protective services workers. Right now we have 3. And the, I believe, if I'm recalling correctly from the state, the average manageable caseload for protective services workers to get is about 20 per month. And our folks are more than doubling that. So thankfully this 4th position, as the older council knows, was funded when the state asked us last year if we needed additional money. So they are aware that even with that position, we're still behind the 8 ball, but they're clawing their way and doing the best they can. Oh, but so the AAA aging folks, they had their fiscal monitoring at the end of the year, and that went very well, and we had no significant issues, which the year prior, we did have some issues because we had been without an accountant for quite a while, and she was able to, now we have an accountant for about the past year, she was able to rectify those. So we are full steam ahead. I just have 2 more items. We had 3 more items. We had we had the DOH, Department of Health, come to Graysdale. As many of you know, they're frequent visitors from complaints. They were there on December 9th because of complaints about staffing on 3 to 11, and staffing levels were perfectly appropriate, and we did not receive any citations for that. So I just wanted to mention that. I'm sorry? Department of Health. Mm-hmm. They oversee Graysdale. I did have another Graysdale item, but I'm drawing a blank, so if I think of it, I'll come back. But the only other thing that I have is very exciting. Most of you know that Kevin Dolan is retiring. His last day is February 21st. And yesterday I made the announcement to our folks that Julie Bader will be his successor. So she is going to be our new administrator effective, I think it's February 24th. So she only has a couple years left with us before she's heads south for retirement. And the hope is it will afford current staff who are newer to the administrative team, supervisory role, it will afford them some opportunities to grow professionally and continue to develop so that we can continue to promote within. So, but we're really excited with that, and Kevin has been working with Julie to ensure we have a smooth transition.
When did you say his last day was?
February 21st, you'll all be getting an invitation for a gathering at the Human Services Building. It's a Friday, and I want to say cake will be around 1, but don't quote me. We'll send you the invite.
Cake.
Well, we're having a meal. We're having a meal for children and youth staff and the administrators, but we don't have funding to invite the free world. Kevin knows a lot of people.
Is Ron Heckman
Council's welcome to attend for the lunch, of course.
that?
Council may have some lunch, of course, not just cake.
It's okay.
Is Ron Heckman the Toastmaster for that ceremony?
That looked like a no to me.
Kevin, I'm the last person Kevin Dolan would want to have.
No comment.
So I guess we want to wait till March to have Julian to discuss children and youth. We don't want to do it in February when Kevin's still here.
Well, I feel like he was, now not just for his speech, but I feel like they were here in the fall, so.
Were they?
I think so.
Oh, okay.
March
I
or
don't even
April?
remember. I thought I had him in the beginning of the year, but okay.
I don't think
we'll
so.
do that.
March or April, yep.
Cool. All right, that's it from you, right? Anything else you can think? Staffing is, 1, 2.
Jess is full. She's fully staffed. Tiff is fully staffed for mental health. Aging is down. One protective services worker, which is the most intensive, highest demand unit. We also have somebody else, Veronica Deck, retiring from the aging division on Friday. She's been here, she just told me, 38 3/4 years. So she had an opportunity to do something else. I don't know what that something else is, and hopefully it's less stressful than here. And if that didn't work out, then she had a great run. And in fact, I will tell you, she said she has not had a single person at the county that she did not get along with, and the county has treated her very well. So it was nice to hear that. So we have a couple openings in aging, and unfortunately, we steal most of our people from children and youth because that's the nature of the beast. So when we're out of civil service, we'll have those children and youth openings filled faster.
And when is that happening?
Working on it. So.
What's the approximate time on that?
Well, it will.
What's the holdup there?
It will. The HR is finalizing their application, and then it goes to the state, which presumably will be somewhat of a holdup because the Civil Service Division just this week officially transitioned to the Office of Administration, I think it is, and they have fewer staff to process our applications and certifications, and of the positions that they have, only one is filled, so they asked us to be patient, so we will try.
You would think they'd be pretty happy to get rid of, this would be more work that they could just.
That is the hope. That is the hope. With our application, it will be less work for them. But
What's
we'll
the
see.
potential projected timeline that it could take? 6 months?
I would love it to be less than a year, but some people have taken longer. I'm hoping that with our career service regs and all the things that the county already had in place, there was very few new things we had to add, very few policies or procedures that we had to put in place. So my hope is that we'll be on the shorter end of less than a year, but we'll see.
Just one other question, not that I want to get into personnel. So if you're having a trickle up in this situation, how many children and youth people are you down?
I believe Julie Bader told me today we have 12 vacancies, which is actually not horrendous, but it is not great. So we have hired, she has done an unbelievable job interviewing and hiring over the last quarter of the fall. But it's an interesting dynamic. Even on the third floor, you have a lot of folks in their, you have your segment in their 20s, in their 30s, and their 40s. We have a whole segment of folks who are eligible for retirement already. And so they seem to go in clumps, which is great for them. They put in their time here, and then we like Lori's hair. But then we end up stealing from children and youth. So the hope is when we're out of civil service, we will be able to fill vacant positions much quicker, so that when aging steals somebody from children and youth, that it will be much less impactful. But as it stands, when I started, I told folks if you were hiring somebody from children and youth, you had to wait 30 days to take them. You couldn't have them in 2 weeks. And there have been times when folks are having to catch up on paperwork, and it takes longer than 30 days, but that's the deal.
That's brutal. And we have no reprieve from the state on that, right? Because I know that's
No, and in fact, Kevin Dolan, I had my monthly meeting with him and Julie today, and paperwork was a huge issue that the admin and the supervisory team met and developed this fairly detailed and intensive plan on how to deal with it. I mean, it's only worse than when the Auditor General's report came out. There's not less paperwork. There is more since then, so.
not surprised. Mr. Hackman, a question?
Just a couple things. Yeah, one, I see how there's really not many options with us taking it over. For years, we tried to get the state to set up a separate classification for children, youth, and family caseworkers because of what you said, and it was also hard to recruit them, and it got into union issues as well. But the state just, they wouldn't touch that. And so I don't think there's any other alternative but for the counties to do that, because you're right, and it's not just, it's every division that's poached children, and children, youth, and family caseworkers are under a tremendous amount of pressure from day one. Many don't know what they're getting into. But I would urge, I just want to say, I want to urge the new members, this is the largest department in the county by personnel and budget. And it's the core, and you'll hear the term core function used a lot. It can be, depending on who you talk to, something's a core and something's not. But I think by any measure, human services is certainly a core function of the county. And it's a big deal. Now, most of the money we're reimbursed, but just like school districts, as time has gone on, the state, the federal government have slowly taken steps backwards in some cases, even though they've moved ahead of others.
Yep.
But it's a big deal, and I just, wanted to echo that because it's very important that we understand where you guys are at.
Yeah, we have, there's about 250 staff in Human Services building, about 800 at Graysdale. I think $240 million budget covering all of that, so it's a lot.
And where are you going with all them extra bodies? You don't have room now.
I told you that when we gave you a tour.
Good Lord.
We're just, trying to think outside the box and just one day at a time. I keep telling my folks, if the state changes, because they're working on changing caseload sizes so that the caseworkers have fewer cases, which would mean we would need more caseworkers, which the only good news is the state at least gives us the reimbursement for the vast majority of that, those costs. But people always say, well, if we get more positions, where are we going to put them? And I said, if you get them, we will find a place for them. Let's just get them. And we are good. We are in a good place. We need to fill the positions we have, and then we'll be good in most areas until some of those regs change, which will be coming at some point.
Thank you.
I
Thank
think
you.
we're good. We can
Thank
bring
you.
Grace down.
Thank you.
Good evening. I'm Jennifer Stewart King, and I am the administrator of Graysdale Nursing Home. It's a 688-bed facility in Nazareth, and we take care of a myriad of different people that come into our facility. So Brian is passing out the report, so we'll go through
Do you
that
want to
briefly.
introduce him and Dawn just to
Sure.
start? Because again, we have new members.
This is Brian Dunlap. He's my assistant administrator. And then Dawn Torres-Feldman, she is the director of nursing. So we are here to answer your questions. So I just want to say Happy New Year.
Same to you.
And if anybody would like to come to Graysdale for a tour, you can certainly contact me, and I'll come on in. Just wear comfortable shoes. It is a big facility.
Is there a number to contact you?
Yes,
Make sure I get it before you go.
absolutely. So currently, we are awaiting the Department of Health to come in on their annual survey. They have not come in. We expected them in December. They came December of last year. I think they're trying to push us back to when they used to come in January, February of past years. So I think they're trying to get us back onto that schedule. So the first page you look at is the Graysdale Census and PPD. So you can look at November's average of our census was 647. The year-to-date average is 655. We were down over the year. We had a series of different instances that took a little dip in our census. We normally used to run 666 to about 670 with how many residents we had in. But we are in the uptick. As of today, we had 652 in. And, I've been in the admissions department since 2010, and it came up from 540. So now we're at 652. It's good.
That's a good question.
Sure.
What's the number we have to reach to get the bonus? You don't know?
But
Brian's the numbers guy.
There previously was a bonus under our Premier contract that we would owe Premier if we hit a certain census. But if you're referring to the dish share, our occupancy needs to be 90% or above. So that's roughly, what would it be, 620 something. And then based on that, your MA percentage then, they allocate different per day rates. But the caveat to that, as going into CHC, they're paying that out a little bit differently.
We run about 94% occupied. We're at, for November, we were 94.04% occupied.
What's CHC?
It is, oh my gosh. Thank you, Community Health Choices. I talk about it all the time. So we just contracted with 3 of the companies. It's AmeriHealth, Cataris, UPMC, and PA Health and Wellness. So we have network.
AmeriHealth?
AmeriHealth. Just say AmeriHealth Mercy. Yeah.
Cataris?
Cataris.
That's part of the AmeriHealth.
Yeah, the umbrella they have. And with the CHC rollout, AmeriHealth has become the majority stakeholder for our residents. Then I believe it's PA Health and Wellness and then UPMC. So.
All right, so what I would suggest, because I have questions about the rollout, so why don't we get through this first and then I'll double back to that.
Absolutely.
That would be helpful.
You want to talk about the finances?
Just completing the first page there, our cost per resident day for November, you will see there was a typo there. It is not $2,297.
Good.
There's an extra 2.
Thanks for fixing that.
No problem. It's 297 with our year-to-date average being 344. And then our Medicare per diem rate, you'll see that there's through October, the all-inclusive is 429, where the room and board portion is 336. Bear in mind that as of October 1st, the Medicare payment structure changed to what you'll hear referred to as PDPM, which is patient-driven payment model that the federal government is using to pay Medicare. If you'll flip to the second page, our revenues. October we're at $5.3 million, which was $200,000 less than compared to September. And our monthly average is actually just a little bit below what we received in October at $5.2 million. Our expenses for November were in 19, they were currently down to $5.7 million compared to $6 million in November of 2018. The overall expenses year to date are $2.6 million more in 19 compared to 18 at $75.2 million versus $72.5 million. And then just a note there about the fund balance. We are still projecting to have a fund balance at the end of the year.
Will it be more or less than what it was compared to last year?
Our projections for this year is showing a reduction, but there still will be a fund balance.
So
Be interesting to see how much.
But the increase in expenses by, what seems like over $2 million, right?
Correct.
What does that do to? Just
We've been, doing facility updates. We
Like
instituted the
Correct. That's going to
Right.
be
Right.
included in there.
the new point-click care system. We had to install a new paging system because our other one went down.
Point quick, is that card access type of thing?
That's actually our electronic health record system, which compiles all of the health records as well as does the billing for the residents.
Before we went,
You guys talk about this, you need to be more informative to those new guys, so we understand.
Yeah, sorry about that.
Yeah, I was going to suggest, if we could do less alphabets today and more full statements.
prior to August, we were in a handwritten chart still. We had like a hybrid system. So we were allowed to purchase a new system, which is completely electronic, which is wonderful. As a matter of fact, Dr. Holmser was here back in November and talked about how good it is to have. Well, St. Luke's just commended us on getting it too, and they are so happy with it. So it's a good purchase.
If I may,
Tie into it?
Ron?
if I may, part of the expense, you mentioned it went up. Would that also then be attributable to one-time expense, like the point-and-click system?
Correct.
So that's something that
Correct.
we won't see, so it should,
As,
okay.
as well as to another big ticket item that we had this year was we purchased all new, it was 32 food carts. And again, the last time we purchased those was 1970, so.
Oh, wow.
Yes. Yeah.
When we opened up the tower building is when we bought the carts last.
Wow.
Good value.
It's awesome. Still good.
It was sad to
Right?
see them go. We've been actually trying to do this for many years, purchase these food carts, and we couldn't get somebody to make them like we need them. And finally, somebody came and was able to.
So they're actually the trays that you roll food on.
Correct.
We have 16 different nursing units that we have to get from the kitchen to the units in a certain amount of time and remain hot, and so we needed them very specific.
Okay. And you found them where?
They came from a company in Danville, Pennsylvania.
Kept it in the state. That works for me. Okay.
Oh, absolutely.
That's very close.
Yeah, it is.
Question. So you're doing electronic documentation now?
Correct.
Okay.
We're not finished with the implementation because it is a long procedure. We're getting to that endpoint, so it's going very well. One of the other what we use is PPD, which is hours of patient care per day. So the state says that Graysdale or all nursing homes in the Commonwealth must go and have at least 2.7 hours per care for the resident. Each resident gets at least 2.7 hours. We run, for November, we were at 3.28. So we are higher than what the state says we have to be. So if you look at the Graysdale admissions and discharges, we did have 40 discharges for the month of November. 24 of them were for deaths. 15 left us to home, and 1 was a hospice discharge. So there were 37 admissions, so we were down, and there were a total of 127 inquiries into Graysdale. So we have about 15 different avenues that come into Graysdale looking for placements. Not everybody comes because a lot of times the hospitals will use us as the last resort if they can't find someplace else to send somebody. So they send us the referral, we say yes, and we wait. So you can look at the staffing and call-offs. This tends to be a huge issue for us. You can see that year-to-date, we've had 5,481 call-offs.
That's crazy.
That's
Yes.
insane.
Is that
Yes.
because it was Christmas?
That was just for November.
Oh, that was November. so
November.
Thanksgiving.
Yep, Thanksgiving.
The
And
5,000 wasn't.
that's the year-to-date.
Year-to-date,
Right, year-to-date.
5,000 people.
Okay. And of that, 1,537 have been through Family Medical Leave Act and the Intermittent Family Medical Leave Act. So we continue to do recruitment efforts. I have November's. We were at Cedar Crest College. We were at the U.S. Military Veterans Employment and Education Fair at the PA Career Link. We went to Lehigh Carbon Community College Career Fair, ESU Career Fair, Lincoln Tech Career Fair, the Literacy Center info table, and we had an open house. We have gotten some people through all these avenues. We continue to pursue every avenue that we can. We are looking at advertisement for not only residents, but for employees, so that is something that we are pursuing. Radio ads and just anything we can get out there to get the name out.
What's the hardest to employ? RNs?
RNs is a challenge, LPNs is probably, now most hospitals can't hire LPNs, so a lot of them it's just through the nursing homes, but it's the 3 to 11 shift that really is the hardest to fill.
Yes.
Question, did you get any referrals yet from in-house? I know we just started that, and I don't know if you can report on that or not. I don't want to know any names. I'm just curious if you got one. Or did I miss that? Because I have to
No.
apologize. I got here a little late.
I actually have this information. So for the tuition assistance program, so what we do is Anybody who has worked for us for a year and has good standing with Graysdale can apply to become, if you're an aide, you can apply to become an LPN or an RN. RNs can apply to be, LPNs can apply to be RNs, and we assist with that. So we opened it back up last year. There wasn't many people coming to the table yet because they had to prove themselves. So we've actually had some great results now. So we had our first person who graduated in August. So then we had 2 people who were chosen for the spring, and they have been accepted at NAC, so they're going through the program. We've had 4 that were just accepted by the committee for the fall of this year. There were 3 LPNs and 1 RN. We just have to wait for them to be accepted to NAC. And then we did accept 3 others, but as of right now, they have not been accepted to NAC, so we're just waiting on those people.
So this is inside.
Inside.
That's kudos.
But this is
That's a
different
good
than
program.
the referral program that you were talking about. You were talking about the
Yeah.
referral
Yeah,
where you
but that's-
incentivize
but that's- I'm
employees
glad you
to
reported
refer.
on that.
Yeah.
Yep.
Yeah, I was.
The referral, I haven't had any
For
information
the
come past me yet.
incentive,
Yes.
monetary incentive.
Yes, I have not seen any of that. I can look into that and I will find
It
you out
just
those
started.
numbers.
Could I ask a quick,
Explain that.
regarding the retention and the CNAs program? Because that's about 2 years now that we've been doing that. How's that working? The training of CNAs and then hiring, and how long are they staying?
Well, we've always had that program in there. It continues to be, and maybe you can talk more about that, the CNA program through staff development. We continue to aggressively look at the high schools and get out there, tell them opportunities to come in to advance their career. Like if they're even interested in nursing, right? Come work as a CNA and then you can see it all and decide whether or not you want to go on to become an RN or an LPN.
Hi, Dawn Torres-Feldman, Director of Nursing. With regards to the CNA training program, we do have quite a few people that apply and go to our information sessions, and a lot of them, I would say, is a second career. They're either right out of high school or they're going into a second career. The ones that are successful, I mean, they go through the whole thing. Some of the second career people just don't finish it. It's a 4-week long program. And then once we interview them at the end, and we interview every single one of them, some of them just say, you know what, it's not for me. I'm glad I came. I'm glad I did it. It was a personal goal, but I can't do it. So I can get the percentages for you for next month, for the next month's report. But last year, I think we were at a 80-something% higher rate from that program. And we have the statistics that, you know, so many people just said it's not for me, and other people maybe didn't pass.
Don't want them if they don't pass. Gotta have quality.
Yeah.
Quality. Thank you.
You have the workers' compensation slide, and this is less than 1% of our workforce. We are affected by this workers' compensation, so that is good news. If you go on to the wounds, infections, and treatments,
I let him use it first.
we are still trending down with our wounds. We had 45 in November, and I can tell you that I just got information for December, and we're down to 36. So we continue to look at every avenue to make sure that wounds are being looked at, monitored. Again, point-click care has helped us out with that because they have a system in place where we can actually take pictures of the wound, and each month the picture goes on top of the other picture to see how you can see where it's healing and look at different avenues. Infections are lower again in November to 64 compared to 93 in October. Again, we're working as a team at Graysdale. So we meet as a team regularly and discuss how we can tackle things. We create performance improvement plans to look at the areas that really need focus on, and we're getting it done. The next slide is incident and falls.
Ooh, go ahead. I had a question too. Go ahead.
I know, going back, is it 2 years now, the bed issue, you know, we have beds at
Bedgate.
Bedgate.
control, and
Bedgate,
we
yeah.
have, and we were concerned also because of the litigating bed sore, open bed sore wounds. How are we doing as far as the wound care? I mean, bed sores in particular.
That is not one of the effects of it. The beds itself,
Well, no, I'm just saying, are we, because we said, well, we have to keep up with that and see, move.
yes,
Are we, where do we stand with over a period of time with bed sweat, right? Open wounds?
we trend down.
Okay.
So we're trending down, and what we're doing is,
I
right,
understand what I was asking.
Yeah.
Right,
No,
so-
I was on the same page. I was going to say, I think this is good.
right.
That's what he's asking.
Right, so what we do is, and we even have this now, we have Medline come in who we got the beds from, they come in and they in-service the floors, they come in regularly and they talk about the moisturizers we use, the washing creams. They in-service on every shift they come in. They are a team partner with us. When we ask, Medline comes in.
Okay, yeah, and the reason I ask is, and you may be aware, a couple of years ago, people came in and we had, and we said, well, we're going to address it and we're going to do this and that. And I just wondered, things are better.
Correct.
I guess, and we're getting, thank you.
And my question, we could talk about this later too, is just, these are November, October, so will we get year data? Because I know you just close
Right.
at the end of this month for December, but.
Yep, you're going to be getting year-to-date data.
Thanks. Because I don't think that tells a picture for new and I know we've been working on this really hard, and I think you've been much more successful long-term with this.
We continue, we had the incidents in falls. We had 143 in November involving 96 residents. The doctors are partnering with us to make sure that we look at those people who have multiple falls. We continue, we have a new risk manager in, and she just started about a week ago, so we are getting her up and acclimated so that she is really deep diving into any incident that occurs with somebody falling, making sure that every intervention was followed. What's the protocol? What did we do? What are the notes reflective of what took place? So we are deep diving into that.
Were we being proactive to try to curtail?
Absolutely. And then we have quality measures. You can see where we continue to be favorable compared to the state average on short-term new and worsening pressure ulcers, which is reflective in the numbers. Long-term, we've gotten better in the low-risk residents who lose control of their bowel or bladder, physical restraints, depressive symptoms, catheters left in the bladder, excessive weight loss. Those are all favorable items that we tend to do very well on. Improvements that we are working on are the short-term self-reported moderate to severe pain. And again, I've explained how that gets judged. So we have something, a report that we have to do to the state, and they look at a 1-week snapshot. And our RNACs, which are registered nurses that have to go in and ask them questions, and they say, are you in pain? Well, in a whole week period, have you ever been in pain? If you answer yes, then you get said that you have pain issues. So we're working with Dr. Holmser on that. He is our medical director, so we're looking at different programs to try to combat that. And you can see falls with major injury. Again, that is something that we are currently looking at with all our falls. We have therapy in on it, the doctors. We have improvement programs in on it. That is our biggest thing that we're trying to fix.
I'm sorry, yes.
Is the state doing anything following up? We've had the discussion before about the antipsychotic. I mean, and we've talked about the nature of many of and I think it's important to note that the county home gets a disproportionate amount of folks with multiple issues, health issues and mental health issues, because at a private home, you can reject them out at the door, but we tend to try and do what we can for our folks. And it's been a problem because they're sticklers, and well, should be. I mean, I've had experience with private homes, and sometimes the drugs are used maybe inappropriately with people. But because of the nature of our population, does that ever come up in the discussions with your association or when we're with the state? Because of course, this is probably one of the most important things we do. I mean, these people's lives are literally in our hands. So training is, anything we need to do to train staff is probably one of the most important jobs in the county. But as far as the drug thing, because we could always be cited at any given day, somebody can walk in and cite. At a nursing home, they can cite you for 100 things if they really wanted to. And you could be the best nursing home in the state. But how is that going anywhere? Is it going nowhere? Is it even a thing?
It is. There are a couple of law firms that have associations that are trying to figure out how to make the state understand that county homes are a lot different than your other homes that are looking at a bigger profit margin. They're going to look at everybody and their numbers to them. So if you are on antipsychotic medications or you have dementia and maybe you have sundowning or behavioral disturbances, well, they're not going to want you because you're going to cause them to hit your quality measures. And we don't look at that because we're here for them. When the families come in and they're lost, they don't know what to do. Who are we to turn them away? We can handle it. We can do it. We have dementia units. We get the doctors, and unfortunately, if it leads to us not having the greatest quality measures, we as a group have to decide, how do we want to go? Do we cherry pick our admissions, or do we say no? The 92-year-old wife can't take care of her husband who's wandering out of the house and has been a resident their whole lives. No, that's our duty. So we are working on it with the associations. We in the 17 other county nursing homes all are have the same issues. So we are.
Yeah, and I appreciate that, and to Mr. Cusick, because I always joke with him about he's one of the, like a Shriner. He has the taller hat with CCAP because he's part of the inner circle of power. But the thing is, I know a lot of counties have sold their nursing homes, but there's still counties that have nursing homes, and hopefully the association, for those of us that have it, are working with your group and trying to help us. I get it. Some sold, and I'm not going to get into that. I'm not in that discussion tonight. But those counties that decide to keep their homes for whatever reason will, in fact, run into the same situation you're talking about.
Yeah, and if I could just follow up on that, the question has become, what is the future of Paca? As we're down to just 17 county homes now, will that organization continue? And I know that there's no longer an executive director there, that position needs to be filled. Yeah, could you explain Paca?
Thank you.
So,
I told you.
so Paca is the Pennsylvania Coalition of Association of County Homes. So there used to be several of us. We're down to 17 right now. It's a group that we meet with, and we look at making sure that we are staying with what the state says. We meet, we talk, we discuss these issues that are going on. We work with the state, the state representatives. We're knocking on doors, and we're talking to them and saying, listen, you have to be fair. You can't treat a private home like a county home, because I can tell you right now, the state is knocking on the county nursing home's door and want us to look at prisoners who can maybe no longer stay in prison, or maybe they're older and they had a Megan's Law, and they're coming to the county and asking us, well, would you consider them? Well, if you're going to ask us to do that, then you have to change some of your ways you look at us, because you're not knocking on the private homes' doors. So we actually are going to be meeting with them this month to discuss that with the county representatives. So it's a give and take, and it is very good that we are with this association. They do handle the IGT money. You know, they are giving it by the state, and then they divvy it out to us.
Intergovernmental.
Oh, yes, that's right, sorry. Intergovernmental transfer.
Anyone who's not been a social worker, this is what we do. We're sorry. Y'all have it in the financial world. We have our own.
That's right.
Okay. I'm coming from a different point of view now.
Sure.
I've spent the last 24 years at a college level. So I'm going to hit you with sanitation.
Okay.
How are you handling cleaning and sanitizing, keeping everything neat there?
We have the best housekeeping crew there is. You can walk into Graysdale and it is clean. You do not smell anything. It does not smell like a nursing home.
That's true.
We are working now with Safe Harbors, who we're looking at disposal of medications, and are we doing it correctly? They're coming in just to consult and to look around, and they did do that, and they were thrilled with we have so many things in place already. You have to come and see it, and you can meet with the housekeeping staff and see our maintenance staff. We are above board.
Okay. Now, have you been hit with the 200-pound bed bug yet?
We have had bed bug issues.
I mean, I'm going to ask you a question because I have dealt with them personally.
Yes.
So at the level I had, we eradicated them.
Bed bug?
In other words, that's
Right.
I understand what I'm saying. I mean, the bed bug issue is a huge issue nationwide. That's why I said a 200-pound issue.
We have had small instances, but that's how good we are. We are right on it.
Okay.
And it has not spread
Okay.
anywhere.
All right, and who's doing your extermination?
It is Ehrlich.
I worked hand in hand with that, so I'm a little curious about. You have to understand something. Where I come from with this, we have been hit with it, and we've had to go in there with the heat treatments and the entire. I've thrown out thousands of dollars worth of stuff. So I just want to know what your approach was on it. If you're going with Ehrlich, I'm quite content with it.
The moment we see, we're on it.
Because you're getting people coming from somewhere else. That's your biggest concern.
Right, and I know 5-star facilities who've had very bad problems.
Really?
Oh, yes.
Found a theater that they took us to and showed us. So those of you who have gone to Broadway, you have sat in chairs that were bed bug infested.
No, I don't.
Thank you. This has turned way into the cautionary tale portion of our meeting. But it's not,
Somebody has some experience with it.
That's true.
200-pound bed bugs.
You call it that because the fact that it's a nationwide problem.
You're right.
It's huge.
Elephant in the room, no question about it. I will say this, I know, and I'm going to just throw that plug in too, because people have gone to Graysdale. I know people have said to me, well, I'm sure about putting a person somewhere. And I said, walk into the lobby. And I know people, and this isn't about a plug for Graysdale, it's just what's happened over the years. I've been involved for so many years. Is they've said, oh my God, I've walked into some really expensive private homes, wood paneling, and the lobby smells like a boys' locker room. And, Graysdale, it's clean, fresh, antiseptic. So that's always been a compliment, I have to say. For anything else, I've always heard, that's always been out there about Graysdale. So I kudos to the people that work on that. But yeah, we always have to be vigilant, I would agree, on anything, because it's such a vulnerable population.
Right, and it's all staff. So as soon as the aides see it, they're calling housekeeping. Everybody works together. It's a great group of people. Everybody knows their job. Exactly, and it does. It works.
So I have a question going away from the bed bugs and back to the reporting measures. Only because I'll forget it if I don't. With regard to the state, and they're coming in and exploring all these things, especially I think it hits me with the pain chart, because we know how old that is, we know where that came from, and it's the standard of care that shouldn't be. How amenable would the state be if Graysdale was proactive in going that next step, So here's the answer we got in the pain chart, so here we did. And then sort of creating your own mechanisms to start to qualify and answer some of those things, whether it be pain, whether it be the falls. Because I know, again, I think of JACO, it's a different organization, but it's the same mentality. They are there to,
What's Jake?
Joint Commission on Hospital Accreditation.
I know,
Thank you.
but I.
But it's like the devil if you're in the hospital system. So they come in and they look for certain things. They tell you how they want to see it. But if you can answer them with good clinical practice, they tend to back off and go, whoa, thank you. So
We can give you an example. We had changed our TB testing to the standard using a quantum gold. So the TB tuberculosis used to be, if you remember, like the little under the skin procedure. Well, we went to the gold standard, quantum gold. Well, unfortunately, the state is looking to do that, but they haven't done it yet. They want you to do the old two-step test. So we have to seek a waiver for it.
A two-step test.
So they won't commend you for going above and beyond.
No.
They'll say, well, we're not there yet.
We had to take it back,
Yeah.
apply for the waiver. It had to get posted on the state's website, and now we have to sit and wait.
So the two-step test, what is
The
that?
two-step test is you'd have it done.
Do you ever get a TB test? You get the
Yeah,
shot,
the
you go
test-
back to
Is
the
that
next
the
letter
little
they
thing
read.
where that has
Yes.
the four
And they go back and
things
read
and
it.
they go like, that was a TB test.
Right,
Huh.
but we have to do ours twice, a
I
week
thought it
apart.
was a shot. Like, I thought that was like, I thought I was getting vaccinated for it. I didn't know. I was a kid.
Anyway, I would encourage you to continue to
Apparently I didn't
keep.
have TB.
Can I address the falls and the
Yeah.
pain? The pain is a measure that is now going to be going away from these reporting measures.
Say that again, I
The
didn't hear you.
the pain measure is going to be going away from the reporting measure, and that's for everybody, it's not just for Graysdale. That's just the quality measure, because I think that they're realizing that everybody's going to have pain, and it's not really.
Especially that population. If
Correct.
you asked my dad on a good day, did he have pain?
Right.
He'll either go no, because he'd
Right.
lie, or he'd say, oh, yes, because she was cute and he wanted more attention.
Yeah.
And, I get it.
So that, excuse me, that is going away. And again, that's just coming off the quality measure for everyone. Regarding the falls, we are now deep diving into our falls, and some of them, we have residents that just fall all the time. It could be disease process, it could be attention seeking, but we are now drilling down on them. So with regards to the falls, we absolutely, we're creating forms to say, hey, these are some suggestions for implementation. Try this initiative. So we're giving that out there. We're trying to re-educate the staff more. And once we are able to do that, then the staff will start thinking independently, like, oh, yeah, I tried that last time and it worked, or it didn't work, but let's try this. So we're trying to help the staff help the residents.
Madam Chairman, I have a question.
I'm sorry.
We'll let her finish her
Oh, I'm
statement.
sorry. I thought you were finished.
No, just to add on to that some of the staff, the newer people, the younger people, they're like, oh my God, there's an elderly person fall, and they back up because they don't know what to do. So we're trying to empower them, say, okay, this is what, try this. And we might do some role playing or, like teach back and re-education. And I think that's key. But again, it's a whole new generation, and it's going to take time to change that culture. So, but we're trying. We are definitely moving more toward education, backing off of the, you did this wrong, but hey, what happened? Let's talk about it. How can we make this better going forward? Instead of being penalized, we're saying, hey, let's offer you this education. So we are definitely moving. Our staff development department are now going to be going around, and even though we're in the point click care system, which is PCC, we are going to start re-providing more information and go with every single staff member and say, hey, do you remember this and this? We threw so much at them at one time with point click care. Now we're just going to follow back up with them so that we're not leaving them hanging. We're following back up. I mean, we had a meeting yesterday.
Yesterday, because now you're into my thing, so we can talk
Sorry,
about it. No,
I'm done.
no, you can stand
Well,
back here and talk about
I
it.
want to ask her a question.
Go ahead.
Before you sit down, you pretty much answered a lot of it, but, and the falls is a big deal, especially with our elderly and the breaking bones. I mean, that's where you get infections. Doctors will say it. It's one of the worst things. And I know things have changed over the years, because at one time we get a lot of staff injuries, and now you have certain procedures with the hoist and everything. So we're training them coming in the door, and we have a continuing training on proactive, before you might see yourself in a situation, oh, I just need a little help getting up. Understand that that's where they may be coming from, and I'm not there quite yet, but I can speak from some experience dealing with some elderly, that your thoughts of what you can do sometimes far exceed what you can really do.
Correct.
So especially with probably the male patients, where they're like, I'm going to be getting out of a bed, I just need you to hold my hand, and he just takes a header.
Right.
And to say, you know what, you can't, and it may mean the person gets mad, and they say, I'm going to tell your boss, but that they know that that's the procedure.
Right.
Don't be conned into.
I live that dream.
And we're also now, we've implemented now that every year, everyone will be retrained on the Hoyers, on certain techniques. We've put that into place last year. So that's something that maybe wasn't always done, but it is now being done annually. So everybody will get that re-education, and if something should happen in the meantime, we pull them automatically and just provide that extra little bit.
Well, it's such a care environment that I know people have said to me, and they told me in the past, well, I mean, what am I supposed to do? It's a 79, well, I don't want to say that. It's an 88-year-old person or 90-plus-year-old person, and they just wanted to get up, and it's like, you're not being unkind to say to somebody who you may even know is a bit difficulty. No, hold on. We'll take care of it, and not to leave them for an hour, but to say, let me get somebody. And we're, because I think there's that sense of, well, I'm not doing them, I'm not being kind to them or something like that.
Well, we're preserving ego and pride too. I mean,
We
when
still
I,
want to preserve dignity. I
well,
mean, you know what I mean? So you
absolutely.
do it-
When you get there and they're like, I can get up, and they're shaky. So, we teach them techniques. Well, just stand like this or do this. So we're trying to teach them other techniques because we do want to preserve that for them.
Absolutely.
And some sense of independence.
People early on, people would say, well, the patients, and we tell staff, they're not patients, they're residents. This is their home.
Right.
It's not a hospital. And most of them know this is it. This is where they're going to live, whether they admit it or not. So, no, you have to keep dignity in mind, but at the same time, safety always comes
Correct.
paramount from our perspective.
And a lot of our people come in from sleeping in a queen or a king-size bed, and the first thing you're put into is back to a twin.
Yeah.
And you're not sure where the edges are, and it's a lot of adjustment. So we have to look at those things, and therapy's in on it, and the staff, we train them, and everybody has a gait belt. The transfer is done with a gait belt on a person to help
Have
move.
those?
Yeah.
I have all this good stuff.
That's
I'm gonna
That's
bring
it.
over.
So we are encouraging staff. If they, the next, we have a, oh my gosh, what are we doing in June for Melissa Schaefer? Putting it online?
The messages?
No. The questionnaire. So we're asking the staff.
Oh, a survey.
A survey, thank you. Oh, we said survey how many times? We're asking the staff, what is it you feel like you're not getting with the training for us? We want them to answer and tell us, because we want to make sure they feel comfortable in every aspect of their job. They need me, I'm there. Dawn's up there, staff development's up there, the ADONs are up there. We're all up there because we want people to show support. Just before I came here, we have some issues going on in one of the units where at change time, it happens to be a dementia unit, the men get a little excitable with each other. And, we've asked one of our sheriffs, just kind of walk on the unit. But a change of shift, then the guys can, look at you and talk to you just because, it's somebody different. So they want to talk to another guy while the change of shift's going on. So we look at different avenues on trying to figure out solutions to stop the fighting or stop the agitation that goes on with different things. So we want to make sure that our staff feels empowered to ask for anything, and we will try to find the solution, the resolution of anything that we can do. One of the things is she had a charge nurse meeting, and we're trying to give the charge nurses more autonomy on their units. Obviously, we give them guidelines, but for decades, a lot of people got their hands slapped for trying to do anything common sense, using their common sense, and we want to give it back to them. If you have somebody from an agency show up on your unit with an earbud on, or it's very disrespectful. This is your unit. You need to tell them this is not appropriate. You can either take the earbud out or you can leave. You know, they shouldn't have to suffer through somebody's attitude on the unit, because if they're giving you an attitude, how's it going to reflect onto the resident? We're not having that anymore. We're done.
And we do have a great group of charge nurses. I mean, it was a great meeting yesterday, and they are excellent at what they do. So we're trying to give that support. And we want them to know that they have our support. We're providing the guidance, but the autonomy is the biggest thing. So
We're making agencies. They're going to have to wear colored scrubs so that it's easier for the families and the residents to recognize agency staff.
Right.
Not only by badge, because it's hard to read, but, you know, our aides are going to be in a burgundy or maroon color. The LPNs are going to be in tan. The RNs are going to be in a black uniform, so that even the staff can point out and say, oh, I know who that is now. She's an agency. So
and what discipline,
Right.
whether the LPN,
Right.
CNA, or RN, that's the key. A lot of families say, well, we don't know who's who. So we're going to start with the agencies. My goal is to have everybody, but we'll start with the agencies.
Sounds good. All right, I'm going to give 2 more minutes. And I see Mr. Myers' finger was up first.
Thank you. What's your numbers, staff-wise? And what's your shifts?
we have 3 shifts.
New, okay.
7 to 3, 3 to 11, and then 11 to 7. Staff-wise, nursing runs about 570.
Around 570.
570, and then total, I think it's like 700.
710 was our average monthly employee number over 2019.
Okay.
Just curious, male-female resident ratio, what is it approximately?
Percentage-wise, like how many female residents we
Yeah, I
have?
mean, that's the overall population.
I would say probably 70-30.
70, 30 female.
Yeah.
I
I have
think you're in that
2
range. I just hadn't asked that in years.
I was going to say, I have a tower unit with 50 all-male, a main building all-male, and then sporadic half units,
Yeah.
but mostly female.
You mentioned people are in a different area?
So dementia patients can pretty much go anywhere. It depends on the severity. So we do have 2 alternative care units, and they're a great unit to go visit when you come, because they have a very structured daily schedule. They have activities going on every day at the same time. They have more staff. So,
I had relatives there, that's why I'm curious.
yes.
Thank you.
Anything else?
Do you still take the TVs for donations?
Yes. If
And
they're,
what size, like if it's too small, like what's too small?
we're up to a 19.
19 or bigger, you'll take them?
As long as it's not like 32, because what they do is they either come out of the wall or hang from a ceiling. So if they're too big, like a 32 would be too big, the aides will get hurt. They'll hit
Oh,
their
so
head.
not bigger than
Not-
a 19?
not 30.
Oh, yeah,
32.
because they're right over the bed.
Correct.
Yeah, you had a flat screen.
19 to 22 inches is,
22?
yeah,
19 to 22?
yeah. And if they have DVD players in them, that's even better. Not that I'm getting picky.
Yeah. Yeah. Thank you.
Okay, I think if there's nothing else, we'll adjourn for this month. I would want to talk to you guys about some stuff we could present next month, because I was going to ask you about the rollout, but it's been short term, so we'll take that and do that down the road.
Okay,
Before you go, I'm going to get numbers so I can call.
absolutely.
All right, meeting adjourned. Thank you.
Thank you.
I'll see you. Yeah, it's an alphabet.
Look forward to it.
Yes.
Jen, I need your phone number also.